Hello my dear audience. A 35 years male, a smoker for the last 5 years, around 10 stick per day, got admitted to the clinical ward with the severe complaint of chest discomfort, very mild form, and some sort of respiratory distress or shortness of breath, very mild form over the last 2 days. Actually that patient was not feeling well over the last 2 days with chest discomfort, no history of fever, cough or chest pain, and most importantly there is no history of chest trauma. With the SIP complaint, we examine the patient accordingly, and with definitive chest finding we proceed for this chest X-ray, and this X-ray is presented here for you. A very important chest X-ray, it is for the medical students. This is X-ray chest view showing the trachea is central in position, most important one, trachea is central in position, and both the diaphragm are quite normal in position, and the pharyngeal gas shadow normal on the left subdiaphragmatic space, and cardiac shield, you may say the cardiac shield is quite normal, or it may be somewhat shifted to the left side, or maybe it may say that you may say that this cardiac shadow is quite normal in position, whatever it is. And then look about the lung field on the both side. On the left side the lung field quite normal, all the zone on the left side quite normal. On the right side the lung field normal on the upper mid zone, but on the lower zone, look at here, on the lower zone there is complete radiolucency. Lucency means black, and radio opacity means a white shadow. So when you will see on the chest X-ray the black shadow, complete black shadow, then it is called radiolucency. And when you will see the white shadow like this, it is radio opacity. So there is complete radiolucent shadow involving the right lower lung field, with definitive collapse lung margin. This is the definitive collapse lung margin, and this is the radiolucent shadow. Okay, and over this radiolucent shadow there is no bronchovascular marking. That means the normal parenchymal radiological shadow not present here. No vascular marking, no bronchial marking are present over this area. So actually this triangular area over the right lower lung field is devoid of lung parenchyma, and on clinical examination there is the finding that breath sound almost absent, percussion note hyperresonant, and breath sound completely obliterated, completely absent. So this is the finding goes in favor of pneumothorax. Which side? Right side. And it is not tension pneumothorax. You know, tension pneumothorax occurs when there is tension. The tension pull the mediastinum towards the opposite, push the mediastinum towards the opposite side. That means the pneumothorax with mediastinal shifting is called tension pneumothorax. But this patient is not with tension pneumothorax but pneumothorax, this patient will be treated as milder form of pneumothorax with observation, and appropriate referral to the cardiothoracic surgery and respiratory medicine department. So this is all about pneumothorax. Thank you very much.